In the name of Allah, the entirely merciful, the especially merciful. This slide reveals a fundamental principle of clinical pharmacology. The pharmacokinetics of many essential drug classes are intimately dependent on their binding to albumin. The list is extensive and covers the bedrock of modern medicine: antibiotics like cephalosporins and penicillins, anticoagulants like the critical drug warfarin, anti-inflammatories like ibuprofen, anticonvulsants like phenytoin, and drugs for the heart, kidney, brain, and diabetes. Why does this matter? Because it is primarily the unbound, free fraction of a drug that is pharmacologically active. Albumin acts as a certain reservoir, binding the drug and making it inactive. This has two major clinical implications. First, in hypoalbuminemia, there is less protein to bind these drugs, leading to a higher free, active concentration and a potentially increased risk of toxicity, even at standard doses. Second, drugs compete with each other for binding sites, displacing one another and suddenly increasing their effects. This is the basis for many dangerous drug interactions. This slide addresses a hidden danger in treating critically ill patients: the powerful interaction between hypoalbuminemia and antibiotics. The core principle is this: many important antibiotics are highly protein-bound, primarily to albumin. When bound to albumin, the drug is inactive and trapped in the bloodstream. It is only the free, unbound fraction of the drug that is pharmacologically active, that can reach the site of infection and exert its effect. Now, consider what happens in hypoalbuminemia. There are fewer albumin-binding sites available. This leads to a higher proportion of the free, active drug circulating in the plasma. For the same total dose, a patient with low albumin will have a significantly higher concentration of the active antibiotic. What are the clinical consequences? Increased efficacy? Unfortunately, no. This effect is unpredictable and does not reliably improve bacterial. Increased risk of toxicity: this is the major concern. The elevated free drug levels can easily exceed the toxic threshold, leading to adverse effects. This is especially dangerous for antibiotics with a narrow therapeutic index, where the difference between a therapeutic dose and a toxic dose is small. Antibiotics are most affected. This is a major concern for drugs like ceftriaxone, flucloxacillin, ertapenem, daptomycin. The bottom line for clinicians: in a patient with significant hypoalbuminemia, you must be vigilant for signs of antibiotic toxicity. In some cases, dose adjustment or therapeutic drug monitoring may be necessary to ensure both safety and efficacy. This slide gets to the precise pharmacokinetic mechanism driving the effects we just discussed. The statement is fundamental: the effects are driven by a decrease in the extent of antibacterial bound to albumin. Let's break down what this means. In a patient with normal albumin, a large portion of a highly protein-bound is inactive. But in hypoalbuminemia, this binding is reduced. This directly leads to an increase in the unbound fraction of the drug in the plasma. Now, why is this so significant? Because of the second part of the statement: the unbound fraction is the only fraction available for distribution and clearance. This is the critical rule of pharmacokinetics. Distribution: only the unbound drug can leave the bloodstream to enter tissues and reach the site of infection. A higher free fraction means more drug is available to distribute. Clearance: only the unbound drug can be metabolized by the liver or filtered by the kidney. A higher free fraction means the body clears the drug faster. So, we have two competing effects: an increase in the active, unbound drug concentration, which raises the risk of toxicity. An increase in the total clearance of the drug, which can lead to subtherapeutic levels over time if the dose isn't adjusted. This is why the clinical picture is complex. The initial higher free fraction poses a toxicity risk, while the enhanced clearance can shorten the drug's half-life, potentially reducing its efficacy at standard dosing intervals. This underscores the need for careful consideration and, when possible, therapeutic drug monitoring in critically ill patients with low albumin. This final point brings all the pharmacokinetic concepts together to predict the net effect on treatment. Because hypoalbuminemia increases the unbound drug fraction, two key parameters change. 1. the apparent volume of distribution, VD, increases. With more free drug available to leave the bloodstream, drug appears to distribute into a larger volume of the body. The drug is less confined to the plasma compartment. 2. The clearance, CL, of the drug also increases. As we said, only the unbound drug can be cleared. With more free drug available, the liver and kidneys can eliminate it more efficiently. Now, here is the critical consequence that impacts patient care: these two increases, a larger VD and a faster clearance, work together to lower the overall drug exposure in the body. We measure this exposure as the area under the curve, AUC. A lower AUC means the patient has less total antibiotic effect over time. This is particularly dangerous for time-dependent antibacterial drugs, like beta-lactams, penicillins, cephalosporins. Their efficacy depends on the time that the drug concentration remains above the minimum inhibitory concentration, MIC, of the bacteria. If albuminemia reduces the drug exposure and shortens the time above the MIC, we risk treatment failure. The dose may be inadequate, even if it's a standard dose, because the drug's behavior in the body has been fundamentally altered. Therefore, in a hypoalbuminemic patient, we must be aware that standard dosing may be subtherapeutic, and we may need strategies like more frequent dosing or prolonged infusions to ensure we hit our pharmacodynamic targets and effectively treat the infection. These aren't just theoretical concerns. Let's look at two powerful examples that demonstrate the real-world impact of hypoalbuminemia on antibiotic efficacy. First, consider ceftriaxone. It is highly protein-bound, at 85 to 95%. In hypoalbuminemic, critically ill patients, studies showed that the volume of distribution and clearance of ceftriaxone were increased by twofold. Think about what that means. The drug is dispersing twice as widely and being cleared twice as fast as expected. This dramatically reduces its concentration at the site of infection. Second, look at ertapenem, which has a similarly high protein binding of 85 to 95%. Researchers observed the same phenomenon, and it had a direct clinical consequence: it led to a failure to attain pharmacodynamic targets. Specifically, for time-dependent antibiotics like ertapenem, success requires that the free drug concentration stays above the bacteria's minimum inhibitory concentration for a certain percentage of the dosing interval, a target known as FTMIC. In patients with low albumin, the increased VD and CL cause the drug levels to drop too quickly, resulting in insufficient time above the MIC. This creates a window of opportunity for the bacteria to recover, potentially develop resistance, leading to treatment failure. These examples underscore a critical message. In a critically ill patient with low albumin, standard dosing of highly protein-bound antibiotics may be subtherapeutic. We must be proactive, considering higher doses, more frequent administration, or even selecting an alt drug with lower protein binding to ensure we effectively treat the infection. The problem we've seen with ceftriaxone and ertapenem is not an exception, it is the rule for a whole class of antibiotics. This slide shows us that the volume of distribution, VD, and clearance, CL, of other highly protein-bound antibacterials are also significantly increased in critically ill patients with hypoalbuminemia. The list is extensive and includes crucial drugs we rely on in the ICU: teicoplanin, a key anti-MRSA glycopeptide; aztreonam, our go-to monobactam for gram-negative coverage in penicillin-allergic patients; fusidic acid, often used for staphylococcal infections; daptomycin, vital lipopeptide for MRSA and VRE. The phrase "significantly increased compared with healthy subjects" is critical. It tells us that the standard dosing regimens, which were often established in healthy volunteers, are fundamentally unsuited for our sickest, most hypoalbuminemic patients. The body handling drugs is completely different in this population. The predictable pharmacokinetics we count on are lost. This creates a perfect storm. The patients who are most vulnerable to severe infections are the very same patients in whom our first-line, highly protein-bound antibiotics are least likely to reach effective concentrations. This isn't a pharmacokinetic curiosity, it is a major clinical challenge that demands a change in our approach, pushing us towards dose optimization, therapeutic drug monitoring, and a heightened awareness of potential treatment failure with these agents. Thank you.